Pelvic inflammatory disease (PID) is an infection of the female reproductive organs, including the uterus, fallopian tubes, and ovaries. PID is commonly caused by sexually transmitted infections STIs like chlamydia and gonorrhea, but it can also result from other non-STD bacteria that spread from the vagina or cervix to the reproductive organs. Prompt treatment of PID is essential, as it can lead to severe complications, including infertility, chronic pelvic pain, and ectopic pregnancy. Causes PID generally develops when bacteria descend from the vagina or cervix to the upper genital tract. The most common causes are sexually transmitted infections. Chlamydia trachomatis and Neisseria gonorrhoeae are the most frequent bacterial infections that lead to PID. These infections can be asymptomatic, allowing bacteria to spread undetected. Non-STD bacteria naturally present in the vagina, such as Gardnerella vaginalis, can cause PID if they enter the reproductive tract. This can sometimes occur after childbirth, abortion, or gynecologic procedures e.g., IUD insertion. Risk factors: multiple sexual partners or a new sexual partner, a history of PID or STIs, douching, which can alter vaginal flora and push bacteria upwards, use of intrauterine devices IUDs, although the risk is mainly within the first few weeks of insertion. Symptoms: PID symptoms can vary from mild to severe, and some people may experience no symptoms at all, which increases the risk of complications due to delayed treatment. Common symptoms include lower abdominal or pelvic pain, the most frequent symptom, often constant or dull in nature. Abnormal vaginal discharge. This may be yellow or green and have an unusual odor. Pain during intercourse, especially deep pelvic pain during sex. Painful urination, due to irritation of the urethra or bladder. Irregular menstrual bleeding between periods or heavy periods. Fever and chills occurs when the infection becomes severe. Nausea and vomiting. In cases where the infection is advanced, diagnosing PID can be challenging, as symptoms may be similar to those of other conditions, e.g., appendicitis, ovarian cysts. Diagnosis generally includes medical history and physical exam. The doctor will review symptoms and conduct a pelvic exam to check for pain or abnormal discharge. Laboratory tests. STI testing. Samples from the cervix or vagina are tested for chlamydia and gonorrhea. Blood and urine tests can help detect signs of infection and inflammation. Imaging tests. Ultrasound can reveal abscesses in the fallopian tubes or ovaries. MRI or CT scans. In cases where an ultrasound isn't conclusive, these can offer detailed images of the pelvic area. Laparoscopy. In some cases, a laparoscopy may be performed to directly view the pelvic organs and assess the extent of inflammation or damage. Treatment. Prompt treatment is crucial for managing PID and minimizing the risk of complications. Treatment usually involves antibiotics. A combination of antibiotics, e.g., ceftriaxone, doxycycline, metronidazole, is typically prescribed to cover a broad spectrum of bacteria. It's essential to complete the full course, even if symptoms improve, to ensure the infection is completely eradicated. Hospitalization. Severe cases, particularly those involving an abscess or high fever, may require intravenous antibiotics and hospitalization. Surgical intervention. Surgery may be needed if there is an abscess that doesn't respond to antibiotics or if the infection has caused extensive tissue damage. Treatment for sexual partners. Partners should also be treated to prevent reinfection and reduce the spread of STIs. Follow-up care. Regular follow-up appointments are recommended to ensure the infection has cleared. Complications. If left untreated, PID can lead to severe, long-term complications. Infertility. Damage to the fallopian tubes can block or scar them, leading to infertility. The risk of infertility increases with each episode of PID. Ectopic pregnancy. Scarring from PID can cause fertilized eggs to implant outside the uterus, usually in the fallopian tube. which is a life-threatening condition. Chronic pelvic pain. Persistent pain in the lower abdomen may continue even after the infection has resolved, often due to scarring or adhesions. Tubo-ovarian abscess. A pocket of infected fluid can form in the fallopian tube or ovary, requiring prompt treatment to avoid rupture or further complications. Preventing PID primarily involves reducing the risk of sexually transmitted infections and maintaining reproductive health. Practice safe sex. Use condoms consistently and correctly to reduce the risk of STIs. Get regular STI testing. Routine testing is recommended, especially for sexually active women under 25 and those with new or multiple partners. Avoid douching. Douching disrupts the natural balance of bacteria in the vagina and can increase the risk of PID. Partner treatment. Ensure sexual partners are tested and treated for STIs to prevent reinfection. Limit sexual partners. Reducing the number of sexual partners lowers the risk of exposure to STIs and PID. Outlook and prognosis. With timely treatment, many people recover from PID without serious consequences. However, recurring infections increase the risk of long-term complications like infertility and chronic pain. Early detection, treatment of STIs, and safe sexual practices are essential to minimizing the impact of PID on reproductive health.